Hello everyone, I am Dr. Darshan JC, Assistant Professor working at the Department of Pharmacy Practice in Yenepoya Pharmacy College and Research Center, Yenepoya deemed to be University. So today I am going to talk about a very important concept under the scheme of pharmacy practice, which is called as drug interactions. So let us begin. So these are the table of contents which includes definition, introduction, the importance and goals of drug interactions, types of drug-drug interactions, factors contributing to drug interactions, mechanisms and consequences of drug interactions, reducing the risk of drug interactions, and finally, how smoking, alcohol and food will affect drug interactions. So by the end of this particular lecture, so one should be able to know what is the definition of drug interactions, a few of the basic concepts with respect to drug interactions, and types of drug interactions along with its mechanisms, and finally the consequences, what could be the potential consequence that can result as a result of drug interactions. So let us start with the definition. So what do you actually mean by drug interactions? So drug interactions are defined as the pharmacological activity of one drug is altered by the concomitant use of another drug or by the presence of some other substances. So when you take simultaneously two or multiple drugs at a time, so there could be a possibility that one drug might affect the other. Means to say, so the efficacy of one drug might vary potentially because of the other drug. So drug interactions pose a significant risk to the patient's safety as well as to the treatment efficacy. Identification and assessment of drug interaction is one of the key responsibility of a clinical pharmacist. So especially at a setting like intensive care unit where patient will be suffering from multiple comorbidities, obviously the patient will be under the treatment of multiple drugs, which we generally say as polypharmacy. So in this setup, it becomes extremely crucial to assess the drug interactions prior and so that you can optimize the treatment accordingly. Understanding drug interactions is key to prevent any adverse drug reactions, promoting optimal patient outcomes. So drug interaction is a reaction that occurs between a drug and another substance that causes a change in the action or side effects of the drug. So it is not necessary that drug interaction is always harmful or always on the negative side. Sometimes intentionally drugs are given in combination so that one drug can enhance the action of the other drug, which we potentially say it as synergism, which we are going to discuss during the types of drug interactions in the next slides. It can cause decrease in the efficacy and increase in the side effects or toxicity, and there are several types of drug interactions which includes drug-drug interactions, drug disease, drug dietary supplements, drug nutrient or food, drug laboratory, and finally drug dietary supplements. So depending upon the agents that interact with each other, so these are the classification. So coming on to importance and goals. So why it is necessary to assess drug interactions right at the beginning or prior to the treatment approach. So prevention of adverse reactions is the first point. So to identify and prevent potential drug interactions that can lead to adverse reactions, reducing the risk of harm to the patients. So as I already said, whenever the patient is suffering from multiple comorbidities, suppose the patient is taking 10 or 15 drugs at a time, it becomes important that we make sure that the efficacy of drug is actually on point. That means they do not necessarily cause any unwanted adverse effects. At the same time, they should be able to show their actual effect. Optimization of therapy ensure that medications are used effectively and safely, achieving the desired therapeutic outcomes while minimizing the risk of adverse reactions. So we know that in case of optimization of therapy, it depends upon the individual patients. So individualization of treatment regimen becomes crucial factor for which it is necessary to assess drug interactions. Next, improvement of patient outcomes. Enhance patient care by minimizing the risk of drug interactions, reducing morbidity and mortality, and improving quality of life. So, assessing the drug interactions is nothing but making sure that patient gets the treatment, rational treatment, making sure that there is much lesser morbidity, that is susceptibility to cause a disease, and also mortality, which is death rate, thereby the entire quality of life of the patient can be enhanced. And lastly, minimization of healthcare costs. So, reducing healthcare cost by preventing adverse reactions, and also we can make sure that we are minimizing the need for additional treatments. So, as I already said, rational use of drugs becomes very important, making sure that the patient doesn't receive unnecessary drugs, so that can optimize the medication use, at the same time reduce the healthcare costs. So, coming to the important concept called object and precipitant drug. So, what do you mean by object and precipitant? So, the drug whose activity is affected by such an interaction is an object drug. That means the drug which is actually getting affected we generally term it as object drug, and the drug which precipitates such an interaction is referred to as a precipitant. That means the agent or the drug which is actually causing the changes in other drugs, we generally call them as precipitant drugs. And the net effect of a drug interactions is, so generally quantitative, that is either the effect will be increased or decreased, seldom qualitative, that is either rapid or slower effect, precipitation of newer or increased adverse effect. So, coming on to the important point, that is drug-drug interactions, which is one of the major type of drug interactions. So, generally on a broader note, it is either pharmacokinetic or pharmacodynamic in nature. Pharmacokinetic interactions occur when concentration of a drug is changed in the body due to change in clearance, peak levels, etc. So, by the meaning of pharmacokinetics, we understand that how the body responds to the drug. That means how the absorption, distribution, metabolism and excretion of a drug will be actually changed. So, that is about pharmacokinetic interactions, whereas pharmacodynamic interactions occur when the effect of a drug is changed by the presence of another substance acting at the same place. So, basically pharmacodynamic is a mechanism of action of a drug, we can say how the drug actually acts on the body. So, we have three types of pharmacodynamic interactions. They are additive, synergistic effect and antagonistic effect. So, what is additive effect? So, additive means total effect which is same as sum of each, in the sense if we are giving two drugs together, so it is nothing but the efficacy of one drug plus the efficacy of another. So, combined together we get a total effect, whereas synergistic effect is a total effect greater than the sum of each. So, I already said that drug interactions could be beneficial if we are using the combination in a right way, so that one drug can enhance the action of the another drug, so that potentially the overall effect is much more than the individual drug. And finally, we have antagonistic effect, that is nothing but one drug is going to diminish the effect of the another drug. So, you can see a picture of mechanisms of drug interactions. There are various mechanisms with respect to pharmacokinetics and pharmacodynamic interactions. As I already said, pharmacokinetics includes majorly four types, which is drug absorption, drug distribution, drug metabolism and drug excretion interactions, and also we have drug transport interactions, which is the least common type, but the first four are the most common ones. So, coming on to drug absorption interactions, which has potentially 5 mechanisms, as you can see here. First is change in the gastrointestinal pH. Second one, you can see absorption chelation or complexation, and third is change in the GI motility, and fourth is induction or inhibitor of drug transport, and lastly malabsorption by the drugs. So, potentially with all these mechanisms, there could be a change in the absorption rate or in the absorption pattern of drugs. And the second one is drug distribution interactions, which includes two primary mechanisms. First one is very important, which is protein binding interactions, and second one is induction or inhibition of drug transport proteins. And third one, we have drug metabolism interactions, includes change in FPM, which is first pass metabolism, metabolizing enzyme induction, metabolizing enzyme inhibition, and finally genetic polymorphism of metabolizing enzyme. So we are going to talk about all these in detail with examples in the next slides. So drug excretion interactions, which is due to change in urinary pH, change in active renal tubular excretion, change in the renal blood flow, biliary excretion, and enterohepatic shunting. And lastly, there is drug transport interactions where because of the induction or inhibition of P glycoproteins or induction or inhibition of OATP. And coming on to pharmacodynamic interactions, as we already discussed, there are three types: synergistic, antagonistic, and additive. So as you can see, additive or cumulative effects and opposing effects or antagonistic effects are the two major mechanisms involved. So coming on to three crucial mechanisms, which are pharmaceutical interactions, pharmacokinetic and dynamic, as we already saw. So what is pharmaceutical interactions? There is a synonym term for this, which is incompatibility, which is a physico-chemical interaction that occurs when drugs are mixed in IV infusions, causing precipitation or inactivation of active principles. So for example, we have drugs like antibiotic, for example, ampicillin, chlorpromazine, and barbiturates, which is a sedative or hypnotic, interact with the dextran in solutions and are broken down or from chemical compounds. That means, so there is some kind of reaction that takes place with the active drugs as well as the infusion, which is dextran here. So they result in some kind of incompatibility, or they result in inactivation of some of the active constituents. Pharmacokinetic interactions, we already discussed that it is absorption, distribution, metabolism, and excretion property of object drug is being altered by the precipitant, and hence these are also called as ADME interactions. So the resultant effect is altered plasma concentration of the object drug. So we know that there are four types under this, which is absorption, distribution, metabolism, and excretion interactions. So coming on to the first type, which is absorption interactions. So absorption interactions are those where the absorption of the object drug is being altered. So what is the net effect then? So either there is faster or slower drug absorption, which we say absorption rate is enhanced or reduced, and then we have more or less complete drug absorption. And what are the mechanisms? We saw it in the flow chart. First one is complexation and adsorption, which is nothing but chelation. So the drugs interact with each other, they form complex, and thereby the absorption of one drug will be altered by the another. It is mostly decreased. And next we have alteration in gastrointestinal pH. There are certain drugs which something like antacids, which will neutralize the gastric acid. So thereby gastrointestinal pH is altered, and depending upon the nature of the drug, their effect might alter. And next one, we have alteration in the gut motility. So enhanced or increased motility of the gut might result in increased absorption rate, and vice versa. Inhibition of gastrointestinal enzymes. We know that there are a lot of enzymes which are involved in digestion and various other physiological processes. So in case those gastrointestinal enzymes are inhibited, there are chances that the absorption pattern of the drugs might also vary. Next, we have alteration of gastrointestinal microflora, and lastly malabsorption syndrome, that is in case of conditions like kwashiorkor or any malabsorption syndrome might also make sure that drugs absorption rate is also decreased. Now we have certain examples depending upon the mechanisms. So we have object drug, precipitant drug, and what influence is being on object drug. So first we can see complexation and adsorption as a mechanism. So the classic example is cephaloxacin or penicillamine antibiotics. as an object drug, and precipitant drugs when it is given with antacids or foods and minerals which contains ions such as aluminium, magnesium, or iron or zinc or calcium, any ions. So the impact will be either there will be formation of a complex, actually they are poorly soluble with such heavy metal ions. So it's understandable that if there is complex formation, entirely the absorption rate might be much lesser because they are much less soluble. So solubility, if the solubility is good enough, then it can enhance the absorption rate, which is not happening here because of the complex formation. And second one, we have alteration of gastrointestinal pH. The classic example here is sulfonamides, aspirin and ferrous sulfate as an object drug. So again, antacids like or sodium carbonate or calcium carbonate, they will enhance the dissolution and absorption rate. As I already said, if dissolution rate is being enhanced, the absorption rate will also be enhanced. So decreased dissolution and hence there is absorption in case of sodium bicarbonate, which is vice versa to antacids. So third one, we have alteration of gut motility. So the examples what we can see here is aspirin, diazepam, levodopa, maxillotin. When it is given with drugs like metoclopramide, there is rapid gastric emptying. So whenever the gastric emptying is rapid, that is whenever the movement of food particles or any other substance from stomach to intestine is rapid, so obviously the absorption rate will also be increased. So we have next example, that is levodopa, lithium carbonate, maxillotin with anticholinergics. There is opposite, that is delayed gastric emptying. So we know that in case there is delayed gastric emptying, then the absorption rate will also be decreased. Coming next, we have distribution interactions. So distribution interactions are those where the distribution pattern of the object drug is altered. So I already said that protein binding being a major mechanism. So where there is competitive displacement interactions, that is there exists a competition between two or more drugs to bind for the same receptor or for the same binding site, especially that is proteins like albumin. So for example, we have anticoagulants and phenylbutazone or chloral hydrate. There exists increased clotting time or increased risk of hemorrhage. So we know that anticoagulants, if in case their effect is enhanced, they might cause bleeding or the increased risk of hemorrhage might take place. And the other example is drugs like sulfonylurea, which is tolbutamide, and sulfonamides. We can see that there is increased hypoglycemic effect because we know tolbutamide being a sulfonylurea, it's an oral hypoglycemic agent. So sulfonamides can actually enhance its effect so that hypoglycemic effect is increased. So these are the examples for competitive displacement reactions, which is nothing but majorly the protein binding drug distribution mechanism. So up next we have metabolism interactions, are those where the metabolism of the object drug is altered. So we have two major types, one is enzyme induction, followed by that we have enzyme inhibition. So what is enzyme induction? Increased rate of metabolism. So we know that all the drugs, they need certain enzymes to get metabolized. For examples, the major class is the family is cytochrome P450, or we have isoenzymes like cytochrome P2D6 or 2C8. We have multiple isoenzymes. So these enzymes are actually responsible for the metabolism of certain drugs. So what happens whenever there is enhanced action of enzymes? So it can increase the rate of metabolism. Just for an example, so if you take any drug which is getting metabolized by an enzyme, in case the action of enzyme is enhanced, that means it is going to get metabolized much faster or much quickly. So as a result, there is increased rate of metabolism. Coming to enzyme inhibition, which is the opposite compared to the previous. So decreased rate of metabolism, because we know that if the action of enzyme is being reduced, which is actually responsible for the metabolism of a drug, so naturally the metabolism rate of that particular drug will also be decreased. So it is a more significant interaction in comparison to other interactions and can be much more dangerous, even they can be fatal. So here we have certain examples. So for enzyme inductions, drugs like corticosteroids, oral contraceptives, coumarins, phenytoins, if they react with sedatives like barbiturates, so what can happen is there is decreased plasma level of the object drug, or thereby we can say that the efficacy of object drug will be decreased. And we have next example as oral contraceptives and oral hypoglycemics, as well as rifamycin, which is an anti-tubercular drug. So again the plasma levels will be decreased because of the enzyme induction. So how plasma level is decreased, that could be a question. So as I already said, if the metabolism rate is enhanced as a result of increased or induction of enzyme, so we know that if metabolism is faster, excretion could potentially be faster as well. So there is no enough amount of drug that is actually present in the blood plasma to show its actual effect. So that is the reason why there is decreased plasma levels of those drugs. So moving on to enzyme inhibition, it is just the opposite, as I already said. So examples like tyramine rich food or monoamino oxidase inhibitors, which we generally say as MAO inhibitors. So there is enhanced absorption of unmetabolized tyramine, and coumarins, if it reacts with the phenylbutyrate, so increased anticoagulant activity, and alcohol, if it reacts with disulfiram, so there is increased in the plasma level. So what it means to say is, whenever there is reduce in the effect of enzyme, so naturally the metabolizing ability of an enzyme is reduced, so drug metabolism rate will be decreased, and as a result the excretion will also be lesser. So what happens is, there is more amount of drug that is been actually present in the blood plasma, so that their action will be enhanced, and that is why you can see enhanced absorption of object drug or increased anticoagulant activity of coumarins. So these are the increased or enhanced effects of the object drug. Lastly, under pharmacokinetics, we have excretion interactions, which are those where the excretion pattern of the object drug is altered. It could be potentially because of changes in the renal blood flow or alteration of urine pH, competition for active secretions, or forced diuresis. So we have certain examples here for the excretion interactions. So the first one is changes in active tubular secretion. Drugs like penicillin, cephalosporins are antibiotics which, when reacted with uricosuric drugs like probenecid, which is generally given for gout, so you can see there is elevated plasma levels of acidic drugs. So that is primarily because of changes in the active tubular secretion. There is also the change in the level of the object drug, which are antibiotics here. So second mechanism is changes in the urine pH. So amphetamine, when given with antacids, so you can see there is increased passive reabsorption of basic drugs, and thereby there is increased risk of toxicity. So just how we saw in case of gastrointestinal pH, how it changes and how it can affect the absorption pattern of object drug, similarly urine pH changes can also affect the object drug excretion rate. Okay, so that is what we call it as excretion interactions. And lastly, we have changes in the renal blood flow. For example, drugs like lithium bicarbonate and NSAIDs, so it can decrease the renal clearance of lithium. We know that every organ in our body needs certain amount of blood for its usual physiological action, so that of kidney as well. So in case there is increased amount of renal blood flow, there is increased excretion, but in case of less renal blood flow, obviously there is decreased renal clearance, and that might result in increased risk of toxicity. Especially drugs like lithium with narrow therapeutic index might cause toxicity very easily. So moving on to next type, so we have completed pharmacokinetic interactions. Now we are going to talk about pharmacodynamic interactions, which are those in which the activity of object drug at its site of action is altered by the precipitant. Such interactions may be direct or indirect. So we have two types of pharmacodynamic interactions, which is direct as well as indirect. So basically pharmacodynamic interactions are those where mechanism of action or the action of object drug at its particular site of action will be modified or altered by the precipitant drug. So let us see what is direct pharmacodynamic interactions. So here the drugs having similar or opposing pharmacological effects are used concurrently. So there is a direct change in the mechanism of action of a drug. So that means it's not because of some indirect pathways which we can see in the other type, which is indirect pharmacodynamic interactions. Here there is straight away the changes that's been induced by one drug in the mechanism of action or the effect of the other drug. So there are three consequences which we already discussed. One is antagonism, addition or summation, and lastly there is synergism. So what is antagonism? So as the term says, anti, which is opposite, so the interacting drugs have opposing actions. For example, acetylcholine and noradrenaline have opposing effects on heart rate. We know that acetylcholine reduces heart rate, whereas noradrenaline will increase the heart rate. Next we have addition or summation. The interacting drugs have similar actions and the resultant effect is the sum of individual drug responses. Okay, so as I already said, if you take two drugs together, drug A and B, so the end effect will be sum of individual drugs, that is drug A plus drug B effects. So example, we have CNS depressants like sedatives and hypnotics, etc. Maybe drugs like alprazolam and diazepam. Okay, when they are given together, there's a high chance that individual effect will be added up and finally we'll get the effect as a sum of both. And lastly we have synergism or potentiation, which is an enhancement of action of one drug by the another. So alcohol enhances the analgesic activity of aspirin is a classical example. So next we have indirect pharmacodynamic interactions. Here both the object and precipitant drugs have unrelated effects, but the latter in some way alerts the effects effects of the former, because we know that in case of direct pharmacodynamic interaction, straight away one drug will have a direct effect on the mechanism of action of another, unlike here where there is a involvement of some indirect pathway which is not necessarily because of the therapeutic effect of that drug. So salicylates decrease the ability of the platelets to aggregate, thus impairing the homeostasis if warfarin induced bleeding occurs. So this is a classical example of indirect pharmacodynamic interactions. So moving on to next concept, which is consequences of drug interaction. So what might happen if there is a development of drug interactions? There could be three chances: either major drug interactions which are potentially life threatening, sometimes they might even be fatal, and then we have moderate, which is deterioration of patient's status, and lastly minor, which are having little or no effect. So how you can reduce the risk of drug interactions? So as I already said, it becomes very important as a clinical pharmacist to assess the drug interactions prior to the drug treatment so that we can minimize the adverse reactions, we can reduce the healthcare costs and optimize and increase the quality of life of the patient. So first up, we need to identify the risk factor of the patient. Suppose the patient is obese or the patient is geriatric. We know that these are the risk factors commonly which can enhance the chances of getting affected by the disease. So next up, we have to take thorough history of the drug. So that is medical and medication history has to be taken so that we understand what the patient is already taking, I mean which particular drug the patient is already been administered with, and so that the current treatment does not affect and cause unwanted consequences which is resulting in the drug interactions. So be knowledgeable about the actions of the drug being used. It's important that we understand the mechanism of action of all the drugs which the patient is been receiving, because we know that directly or indirectly they might have effect on each other, which is pharmacodynamic direct or indirect effects. So next up, we should consider the therapeutic alternative. We have multiple options in the same drug. Sometimes there could be drugs falling in the same class with slightly different side effect profile or the efficacy profile, which might be much better option for the particular patient. So we need to consider all the factors which is patient related and choose the drug accordingly. It might be in the same therapeutic class or different therapeutic class, but make sure that there are alternative options to the drug. Avoid complex therapeutic regimens whenever possible. So try to give as less drug as possible. Suppose now a patient is suffering from a disease which is potentially can be cured by maybe 3 or 4 drugs, but sometimes irrational drug prescribing might take place, which is giving unnecessarily 7 or 8 drugs which are actually not necessary for that patient. So it's important to avoid such complexities in the therapeutic regimen. Educate the patient, that is giving thorough patient counseling in terms of disease, in terms of what drug the patient is being administered with, becomes very important for enhancing the adherence as well as to make sure that drug interactions is reduced. And lastly, monitor therapy. So whatever the drug it's been administered to the patient, should make sure that that particular drug is actually being effective to that particular patient. So the next concept is influence of smoking and alcohol on drug interactions. So we know that smoking and alcohol have their own potential harmful effects. So what impact they can have towards drugs? So we have certain examples here. Smoking increases the activity of drug metabolizing enzymes in the liver, which might result in unwanted consequences. So with the result that certain therapeutic agents, for example, diazepam, propoxyphene, theophylline, olanzapine, they are metabolized rapidly and their effect is decreased. So whenever patient is on treatment course with these drugs which I have mentioned, and if the patient is a potential chronic smoker, there are much more chances that these drugs might be metabolized rapidly, because they might cause enzyme induction and thereby the rate of metabolism will be much faster. So what happens if the rate of metabolism is faster? That is nothing but the effect is decreased. As I already said, faster the metabolism, faster will be the excretion, and the amount of drug that is actually present in the blood circulation or blood plasma is much more lesser, and as a result the effect is decreased. Chronic use of alcoholic beverages may increase the rate of metabolism of drugs such as warfarin and phenytoin, probably by increasing the effect of hepatic enzymes. So we know that already the smoking can increase the metabolism of certain drugs. Same like that, we can say that alcohol can also increase the rate of metabolism of these drugs, especially warfarin and phenytoin. So the activity of hepatic enzyme is increased and the effect is again decreased. So acute use of alcohol by non-alcoholic individual may cause an inhibition of hepatic enzymes. So influence of food on drug interaction. So we know that there are other type of drug interactions as well. It's not just drug, it can be drug food interaction. So it becomes important what diet are you in whenever you are taking certain medications. So food affects the rate and extent of absorption of drugs from the gastrointestinal tract. Example, many antibiotics should be given at least 1 hour before or 2 hours after meals, so that their absorption is actually achieved in an optimal way. So it's important that the food doesn't interfere with the absorption of drugs. So at the same time, there are certain drugs which you cannot intake without in an empty stomach, so they might cause gastric irritation as well. So the type of food may be important with regard to the absorption of concurrently administered drug. So for example, we have dietary items such as milk and other dairy products that contain calcium may decrease the absorption of tetracycline and fluoroquinolone derivatives. So how it decreases actually? So for example, tetracycline, and when you take milk or calcium based products, so what happens is, so calcium can actually form the complex. So it reacts with tetracycline and it can result in chelation, which we already discussed when we talked about the mechanisms of absorption interaction. So thereby, because of the complex formation, the absorption rate will be decreased. So that is why you can see there is much more decreased absorption as well as decreased efficacy of these drugs, that is tetracycline. So to summarize, changes in drug effects when taken together, so it can be either beneficial or harmful. So it is important that we use drug in combination so that it can be synergistic, that is potentially one drug might enhance the action of the other drug, unlike on the other way where there are chances that one drug might decrease the effect of another drug, causing unwanted consequences. And drug interactions are a significant concern. It is very important that especially in ICU setting, one should make sure as a clinical pharmacist to identify the drug interactions and suggest any alternative recommendations if there are any major drug interactions found. So drug disease, drug dietary supplements, drug nutrient or food, drug laboratory and drug dietary supplements are one of the major types of drug interactions. Pharmacokinetics and pharmacodynamics are the two types of drug-drug interactions. Understanding the types and mechanism becomes much more crucial so that we can optimize the therapeutic regimen based upon the interaction found. And lastly, prevention and management strategies can actually minimize the risks. So these are my few of the references. Thank you.